Assalamu alaikum. Today I wanted to talk about analgesia. A lot of procedures that are done in dentistry would lead the patient to have pain. Some painful episodes are only a few hours long and some could last days. An example would be if you were to do a couple of restorations on somebody, then the pain or discomfort should last no longer than the evening and they should recover from it. And simple paracetamol, about 500 milligram of one tablet, should be enough. In pediatric cases, all you got to do is give either paracetamol or ibuprofen syrup. One spoon once, even before the patient leaves the operatory, would take them through this episode and they'll be fine. I try to keep the prescription of any medication to the bare minimum and only prescribe it if I anticipate the patient to suffer with pain. Having said that, if you're doing wisdom teeth extractions, you're doing root canal therapies, or if you're doing implants with sinus lift or bone graftings and whatever have you, then there is reasonable expectation that the patient would have pain. And the pain would be from moderate to severe in caliber. So to tell the patient to go ahead and take just like a brand name Synflex or something would be a major disservice to the pain. One thing you must realize is that when you're doing RCT, root canal therapy, you are dealing with inflammation, periapical inflammation, and that inflammation rests inside the bone. When you're doing wisdom teeth extraction, you're dealing with bone and soft tissue both, and you are causing some trauma or cutting the bone. And that should result in inflammation and pain. When it comes to implant placement, you're drilling into the bone or you're subcompacting the bone, and of course that would cause pain. When it comes to sinus lift, you're again dealing with bone. So in essence, it's the bone that causes most of the problems, not the soft tissue. Soft tissue is much more tolerant to procedures compared to bone. Having said that, it is the inflammation, the reaction of the body to the stimulus, traumatic stimulus, that causes a pain. So what I do and what has worked like a charm for many years now, over a decade and a half, almost 2 decades, is that I start out, if I'm doing RCT, I would give a little bit of periapical dose of dexamethasone. Compared to non-steroidal anti-inflammatory drugs, NSAIDs, this is a SAID, steroidal anti-inflammatory medication. It's dexamethasone. If you're giving one-time dosage of up to 4 milligrams, it is within safety limits of 6 milligrams. If somebody is going to have Addisonian crisis after repeated uses of dexamethasone, they would need to have more than 6 milligrams for about 5 or 6 days. But giving one-time dosage of 4 milligram, that's how one ampule comes in 4 milligrams, and it'll be 1 milliliter. So what I do is I would use insulin syringe. Insulin syringe is 1 milliliter in volume, but it has 100 gradations on it. So for every side that I'm working on, per quadrant, I would give 25% of it, which is a quarter milliliter, which turns out to be 1 milligram alone. So you would take a vial and you draw out 25 units in an insulin syringe and go wherever you have done the root canal therapy, go to the periapical region, just like giving local anesthetic. You go ahead and deposit that 0.25 milliliter, which is 25 units on an insulin syringe, periapically right after the treatment or even during the treatment, and that would cause calmness of the area, so the inflammation would set in. Once the inflammation doesn't come in, then of course you should not expect pain to happen. So that's the first thing you should do. You should nip the inflammation right in the bud. Second thing to do is I would give them a good strong anti-inflammatory agent as a intramuscular injection. Ketorolac 30 milligrams seems to work wonders. It's a great medication. You got to get injected intramuscularly. That means you use a regular 3 cc, 3 milliliter syringe, draw out the fluid in it, and that Ketorolac one little ampule, which is of 30 milligram quantity, it is about 1 milliliter. So you use a 3 cc syringe and you go into the muscle. A lot of people would like to give an injection right here in deltoid. I like to give it on the side where you tie your belt. There's good muscle there, there's good volume of tissue there, and people don't feel pain there. We can talk about where to inject a little later, but that's a good site to get the injection in, and that would be given immediately post-operatively. That way the patient has pain control with Ketorolac, which is a strong medication for moderate to severe pain, and the patient will be pain-free. After the first injection, I would tell the patient to take celecoxib. Celecoxib is a NSAID again. It's a very good medication, very strong. and I would recommend that to be used in 200 milligram dosage 3 times a day for the first 3 doses, and then twice a day for the next 2 days. By this time, all the sequelae is over and the patient is totally pain-free. So after the second day, I would call the patient and say, how are you feeling? If you have any trouble, any pain, they would like a little bit more sustaining medication, then I would step them down to naproxen sodium. Naproxen sodium 400 milligram or 500 milligram 3 times a day for another 2 days in case they need it is more than enough. So what this does, this provides you coverage for the first full day with very first injection is ketorolac, then the very first day is with celecoxib, and then the next 2 days are also with celecoxib. First day is 3 times a day, then the next 2 days is only twice a day. And in case they needed fourth and fifth day something, then naproxen sodium itself works wonders. This, like I said, has worked for decades for me, couple of decades approximately, and it has kept my patients pain-free. One thing you can substitute ketorolac with is diclofenac sodium, but then diclofenac sodium would need to be used at 75 milligram. I have used it in the past quite a bit, but I think ketorolac works so much better than diclofenac, and it is almost 4 or 5 times stronger. We have other medications in our operatory also that we can use, but they fall into the category of sedatives, and I would like to discuss that sometime separately, and that would also help the patient get over the anxiety. It would sedate the patient in your operatory, and it would provide analgesia, pain control at the same time, and you'll be able to do better treatments for a longer period of time, handling the patient anxiety altogether. Having said this, I hope this helps you in your pain control. Your patients will be happier, you will be happier also, and you'll feel confident in doing treatments, and your patients will be thankful to you that they can get dental treatments done without having to suffer through pain. In case you need this protocol, I have posted it on internet also, and I'll post a picture of it separately. But in case you need it, go ahead and send me a message at drqdds@gmail.com. That is drqdds@gmail.com, drqdds@gmail.com, and I'll be happy to share the PNG or JPEG image of the protocol that we use. One thing that really also helps when it comes to prevention of infections is that I would have the patient rinse with chlorhexidine gluconate oral rinse before I do the treatment, and sometime even during the treatment. That keeps the oral bacteria count low, and of course that helps in healing much better afterwards, that you are not introducing infection into the soft tissue. I hope that helps. Sayonara.